I'm going to stop sharing for just a moment. I think we're at 12:53. So, hi everyone. My name is Katie Hubner. I am a TA provider with Social Change Partners. We are working with counties all across the state on the implementation of FFPS programming and comprehensive prevention plans. I also have spent the last 2 years working with the Public Works Alliance on some demonstration pilots around CalAIM and thinking about how to better use Medi-Cal to fund prevention services. And before we get started, I was hoping to get a sense of the mix of folks in the room. So rather than doing a formal poll, can we do like a hands up? So can you raise your hand if you, or actually let's do the thumbs up button. Can you give me a thumbs up if you are associated with a child welfare agency or other public agency? Okay, so a decent fraction of you, but not the majority. Okay, go ahead and lower your thumbs. Can I get a thumbs up if you are affiliated with a community-based organization or a direct service provider who is not a public agency? I see lots of thumbs. Okay. Okay, great. Thank you. This is perfect because what I am hoping for today is I'm going to take you all through some high-level slides that are really just talking about the intersection of Medi-Cal and prevention service goals, and particularly where that might impact community pathway design. And then after about 30 to 40 minutes of presenting, we're going to switch into discussion mode. And we're going to work through some scenarios, talking through just practicing like how could Medi-Cal be leveraged to address some community pathway needs, and what are some problems we should expect to arise, and how can we problem solve around them. And so for that purpose of the discussion, this is a slightly bigger group than I expected, but I will phrase the question and folks can raise their hand and jump in as they like. And then for the very last 10, 15 minutes of the slide, I will talk through some of the implementation challenges that agencies should be prepared for, or FFPS planning teams should be prepared for. And I'll just offer now that the universe of Medi-Cal funded services is broad. The possibilities of Medi-Cal to fund prevention services is also broad. And so we are only going to be able to scrape the surface today. But I'm very responsive to if folks have follow-up questions or materials requests about where they could learn more about a specific topic. I'll end on my email, and folks are more than welcome to email me, and we can continue the conversation after. So with that in mind, let's get started. Okay, so the question for today is, can Medi-Cal pay for the community pathway? And the spoil alert is yes. Medi-Cal can offset costs associated with community pathways such as staffing, outreach, and program planning and other administrative activities if certain conditions are met. And so the ability to bill Medi-Cal is highly dependent on how the community pathway is structured, what services are being offered, how they're staffed, how you track service delivery. And so we'll talk a little bit more about that today. But I think, the focus is really thinking about this approach from the beginning of how you are designing your pathway, rather than after the fact.
Hey, Katie, we're seeing it in presenter mode right now.
Okay, let's try starting over. I think what changed is that I tried showing screen and then not. So let's try this. I am not currently sharing screen right now, correct?
Correct.
From the
correct.
Okay. So Is it?
Okay, so that looks great.
Okay. Thank you for that heads up. I appreciate that. Um, and note to self to be cautious about stopping sharing. Okay. So let's start with some basics about Medicaid. Medi-Cal is California's version of Medicaid. Medicaid is a federal entitlement program that provides free or low cost medical, mental health, dental, and other services for low income children and adults. It is administered by the Department of Healthcare Services as the sole state Medicaid agency, and it is funded through a mix of state and federal funds. The reimbursement rate can vary depending on the service provided, who the service is being provided to, and other administrative details. But practically, we generally think about it as you spend $1 and you get 50 cents back. So this is a federal match rate that's very comparable to 4E prevention. The exception, which we'll talk about today, is Medi-Cal funded services that are offered through managed care plans. Those services do not require a local match. Let's talk a little bit about who is eligible for Medi-Cal. All children living in families that make less than 266% of the federal poverty level are eligible. In 2026 numbers, that is $87,780 for a family of four. Adults have a lower bar for qualifying, or I should say a higher bar for qualifying. For them, it is less than 138% of the federal poverty level, which is about $45,000. And with HR 1 going into effect, this significantly restricts Medi-Cal eligibility for adults by introducing mandatory work requirements, increasing redetermination frequency, reducing retroactive coverage, and tightening immigration status. However, HR 1 doesn't significantly impact children and youth eligibility, and some services for parents can actually be covered under a child's benefits if they're of direct benefit of the child to the child. So this can cover things like transportation assistance to appointments, parent education needs, even in some cases connecting the parent to mental health and substance use support services. And so I would advocate that you consider thinking about the possibility of Medi-Cal, even in the face of HR 1. And I will also say that the vast majority of families who interact with the child welfare system are Medi-Cal eligible, but it is not everyone. And so that is, I think, sometimes one of the limitations of looking at Medi-Cal funded services, and particularly in the community pathway. And we'll talk about this later as well, but not every family who walks through your door will be Medi-Cal eligible, but most will be. I share this slide to just really emphasize the difference in scale and point to reinforce the idea that Medicaid and Medi-Cal funding impacts many more people and underpins the many, like basically every child and family serving system in the state, not just child welfare. And so when thinking about just scale of possibilities, Medi-Cal is significant. Unfortunately, that also makes it more complicated, right? Let's talk a little bit about CalAIM, because CalAIM catalyzed the conversation around how to use Medi-Cal for prevention services as it unveiled. And so, back to the basics, California Advancing and Innovating Medi-Cal, that is CalAIM. It actually encompasses several multi-year initiatives. But as a whole, it is focused on quality, equity, prevention, and whole person care. Where this impacts prevention planning is the explicit focus, not just on like chronic health needs, but really looking at prevention to prevent chronic health needs. It prioritizes the highest needs populations, including foster youth and child welfare involved families. And it also shifted the focus to managed care plans. Managed care plans are a new partner for some county planning teams. However, they're incentivized to address prevention needs to prevent costly care later. And a benefit, as we discussed before, their services don't require a local match. So you don't have to first put up the dollar to get that 50 cents back. Most managed care plan services are fully capitated, meaning they cover the costs. So CalAIM created several opportunities for child welfare agencies and family first prevention planning teams. And there are many beyond what is listed here. But today, what we're going to touch on is the new provider classes. So these are staffing roles that can help connect individuals to services. And I think importantly for some counties, they're staffing roles that can be staffed by folks with shared cultural or life experiences to the people they're trying to serve, which has been identified as a priority by community advocates in many places. It can open up funding for prevention activities not funded by 4E prevention, particularly the more upstream outreach and education activities. It created access to concrete supports through community supports, and it created new benefits that can support care coordination, like enhanced care management. As I said before, it also expanded the role that managed care plans could play in supporting both child welfare, like foster care families, as well as child welfare involved families who are not necessarily in foster care, but are at imminent risk of involvement. So the same target population as 4E prevention services. Before I get into the community pathway, let me pause quickly for questions. Are there any questions, or Regina, did I miss anything in the chat?
There was a question in the chat
Okay.
from Timothy. If community pathways activities are funded by FFPSA, which draws down a federal portion, then how can you bill Medi-Cal, which also draws down a federal portion?
So one of the things that I will be presenting today is that there are activities in community pathway that 4E prevention doesn't fund, and that is where it makes sense to look to Medi-Cal. 4E prevention doesn't kick in until after a family has been assessed, recognized as an eligible family through the 4E candidacy process, and signed a family well-being plan. So that means the family has already gone through enough engagement to get to a place where they need a certain level of case management and have agreed to engage. But it doesn't pay for all the work that goes into that. And so, really, this is an opportunity to blend and braid funds, to use Medi-Cal for the further upstream work, and then transition to 4E for those families who need longer term care. And we will talk about that in more depth when we go through the scenarios. Any other questions?
Yes.
It's a great question, and you basically signposted all the slides to come.
So there's several. So Michelle wrote in here, since CalAIM programs are primarily delivered through MCPs, how does this impact eligibility and access for those who have Medi-Cal but are not enrolled in MCP? So 90%
of Californians who are on Medi-Cal are enrolled in a managed care plan. And so if you have a family who's walking into the door of your community pathway and they have Medi-Cal, they are probably enrolled in a managed care plan. The exception is usually very specific populations. Like, for example, in some counties have a practice of disenrolling youth when they come into the foster care system. They disenroll them from their managed care plan and put them into fee for service. But the general family on the street on Medi-Cal is accessing care through a managed care plan. Now, what it means to work with families who are not connected, or individuals, I should say, who are on Medi-Cal but not connected to a managed care plan, is that there's a limitation on the services you can offer them, because some services, like enhanced care management, are exclusively available through managed care plans. And this would be considered a Medi-Cal administrative activity for those who are looking into billing MA. One of the things you could do as part of your community pathway work is connect families to a managed care plan if they would benefit from the services offered through a managed care plan. Other questions?
So Amber wrote, remind me of HR1. Is that the big, beautiful bill? And do you access the new provider class?
HR1 is the big, beautiful bill, although I refuse to refer to it as that way. I refuse to refer to something that cuts access to Medi-Cal as beautiful. The new provider classes are, they are not impacted by HR1 directly. However, different provider classes are funded through different mechanisms in CalAIM, and there is a possibility that that basically managed care plans may choose to de-emphasize some provider classes in the future. And community supports are not technically a benefit, and there is a possibility that as the waiver expires, some community supports will go away. And I think the fact that the landscape is evolving emphasizes why, when planning teams are thinking about how to use Medi-Cal for prevention services, it is a conversation that needs to include lots of stakeholders, including your managed care plan partners. And then I think in the interest of time, I can take one more question, and then I'm going to push us through the next set of slides.
Can you just say what HR stands for? Is that health reform or what? That's really what I meant. And I appreciate what you said about the big, beautiful, whatever it is called.
Yeah, I actually don't know what the HR stands for in HR1. I can Google it after the fact and follow up with you if you like, but I don't know. Okay, so let's talk a little bit about the community pathway. The community pathway, for those of you who are not familiar, is intended to create access points to services that can strengthen families and maintain family stability in order to lessen the involvement or lessen the probability of formal involvement with the child welfare system. It's intended to connect families experiencing challenges to services voluntarily and without stigma, and really to minimize the trauma of getting help. It can be centralized through one agency, or it can be structured as a decentralized network with multiple access points and service providers. And what I mean by this is that for many counties, they might be starting by standing up one community pathway. Maybe they're working with one FRC, or they're working with one clinic, or one, maybe a school. But over time, your community pathway could really be a whole network of providers offering different services. And what makes them part of the community pathway is that they have the capability of assessing families for 4E prevention services and providing those services and going through the claiming process. So the idea with the community pathway is it's quite flexible, both in how it's operated and also how families can access it. So families can self-refer, or they can be referred via another agency, right? So for example, schools who might have, in the mandated reporting to community supporting model, a school that might have made a CPS call for a child who was demonstrating needs that were significant but didn't necessarily signify abuse, could instead direct that family to a community pathway provider. And as I said, it can be offered in this variety of settings, everything from community centers, schools, family resource centers. Some community pathway programs are even administered by other public agencies, the most common of these being the home visiting programs that are often operated through public health systems. And then community pathway providers may be direct providers of a specific EBP, or they may hold more of a assessment, case management, and service navigation role. And so what I mean by that is, for example, they may sit in a family resource center, meet with families as they are referred or come in, complete the 4E candidacy assessment, identify the family's needs, and then hold the case management role, but refer the family to specific services and EBPs as needed. And this flexibility is really important, this concept that there are no restrictions on who can be a community pathway provider or where those services are offered, because it allows you to design around the intersection of community pathway needs and Medi-Cal funded services and CalAIM priorities. So what I will say is that there is significant overlap in the goals of CalAIM and the goals of community pathway. both CalAIM and the community pathway are focused on identifying and addressing family risk factors that, if unaddressed, may put the family into a crisis that necessitates some sort of formal intervention. For Medi-Cal, the focus is on promoting health and well-being and avoiding costly placements like hospitalizations, psychiatric holds, and inpatient rehabilitation. And this is where that shift to managed care plans are important, because managed care plans basically get paid a fixed rate for families, and then that family becomes more expensive for the plan if they have more severe needs. And so managed care plans are financially incentivized to connect families to prevention services that lessen the likelihood of hospitalizations and other expensive treatment options. For child welfare, the focus is really on minimizing trauma and preventing formal system involvement. And once families become formally system involved, they often get referred to services that are Medi-Cal funded, like specialty mental health services, substance use treatment services, et cetera, to stabilize the family. And so you can see that there is an overlap in goals and incentives between these two areas. And while they share these early intervention goals, I am positing to you that Medi-Cal has more flexibility to offer upstream primary prevention. And so here's an example of that. Based on my experience talking to community advocates as part of needs assessments for CPP design, as well as working with different counties on how they are thinking about their community pathway, we see a disparity between what they want to offer and when FFPSA funding becomes available. And this goes back to Timothy's initial question, which is that, for example, imagine an FRC who wants to become a community pathway provider. Not every family who walks into the door of that FRC looking for support is looking for the level of support that implies intensive ongoing case management, which is where FFPSA funded EBPs really kick in. FFPSA doesn't fund like light touch and refer, because a family first has to be assessed for like risk factors being in place, and they have to like build a plan that implies ongoing receipt of a specific EBP. So for families who are coming in looking for help, but more of a brief intervention, depending on the need, there is a possibility to cover that need through a Medi-Cal funded service. And this underscores my prior point, which is that, when you talk to community advocates about what they want out of the community pathway, they often bring up things like housing assistance, cash aid, support with childcare, support with parenting education, support accessing food. And they want that, and they want as many families as possible to qualify for those services. And unfortunately, 4E prevention funding really only kicks in for families who meet the imminent risk threshold and need support in one of the evidence-based practice areas, which are specifically around substance use treatment services, mental health services, and in-home parenting skill development. The other problem, which I referenced in answering Timothy's question, is that administering the community pathway requires funding an extended engagement journey that includes outreach, relationship building, completing the initial assessments, identifying the supports a family needs. And as I said, FFPSA funding only supports costs for identified families that have already met the eligibility requirements, and it doesn't kick in until they've created that family well-being plan. So when you're looking at the front end of funding the service, the costs associated with the community pathway, 4E funding doesn't really cover that initial outreach and engagement work. But those activities could potentially be covered through Medi-Cal.
So Katie, we have a few questions. Our chat is real hot right now.
Okay.
To answer some of the questions, I accidentally skipped Alan, but it seems like a lot of people are responding. And it says, I may be jumping ahead, but with CalAIM ending after this calendar year, what can we look forward to for the future opportunities?
So the Medicaid waivers may end after this year, but many CalAIM services won't go away. I don't expect community health worker services to go away. I don't expect enhanced care management services to go away. And so my advice is to continue planning for what we know is possible and being in conversation with managed care plans and the state about, what is coming. The reality is we don't have a crystal ball for what the Medi-Cal landscape is going to look like in 2027, 2028, 2029. But I think what we are seeing is that as available funding shrinks in other spaces, we need to be more creative about accessing funding where we can. And as that slide showed the difference between 4E funding and Medi-Cal funding in California, Medi-Cal is a large pool of money. Other questions?
Another question is, can community-based organizations do both CalAIMS and Community Pathway?
Yes. They can't bill the same service to both sources, but they can provide services that bill to both services. And I think when we go through the scenarios, we'll give some examples of what that might look like.
And I had one more question from Lucy. Do FRCs need to have an agreement or contract with the MCP, or can you just be subcontracted by an entity that has the agreement with the MCP?
It really depends on the service you're providing. And so, for example, enhanced care management, you can go through an intermediary. For community health worker services, you would first actually need to be registered with DHCS and then contracted with the managed care plan. And we'll talk about this stuff in more detail later. And then for some, like for example, for Medicaid administrative activities, you wouldn't contract with a managed care organization at all. You would contract with your local government authority agency who administers CMAW funds. And we will talk about that in more detail. That's in future slides. Any other burning questions before I go through? We're only about a third of the way through my slides, so I do have to probably pick up the pace. So there are, as I said at the beginning, there's significant opportunities that CalAIM created. I'm going to focus on 2 for today, but they are by no means the only 2. So the first one I want to talk about is community health workers. CalAIM created new provider classes, including community health workers, who can, this role can essentially fund staff whose primary job duty is to provide early outreach, advocacy, and engagement efforts. So that exact space we were just talking about isn't currently funded through 4E prevention services. And it can also fill the gap of providing education and referral support for those families who are just looking for light touch navigation support. So that problem number 1 slide that I brought up. Community health workers generally provide face-to-face preventative health services. They can bill up to 2 hours a day per beneficiary. And the first 3 interactions they have with a beneficiary doesn't require any prior authorization. And so what that means is that if you have certified community health workers in your organization, they can provide up to 6 hours of outreach to a family before you need to go and get confirmation that this family meets any extenuating eligibility criteria. And the qualifications to receive CHW services, the bar is very low. The other thing I just want to point out is that CHWs can help address a number of conditions, and some of them are not what we would normally think of as healthcare needs. So the services they can provide can include coaching, goal setting, education. It can include screening and assessment. It can include advocacy. It can include support accessing care and navigating, cultural pitfalls. And it can encompass a broad range of scenarios. So these are just a few, right? The examples that I wanted to lift up are helping a parent access mental health and substance use services, helping a parent find transportation and childcare for when they're attending their child's medical appointments, coaching a grandma to be able to manage her health issues while also caring for her grandkids if she's the primary caregiver. I think a big one is educating new moms on the importance of prenatal and postpartum health care. helping youth access services for sexual or reproductive health. And then I think an area that is often a struggle to find funding is initial support with connecting members to domestic violence or intimate partner violence support services. There's also a violence prevention category as well for folks who live in neighborhoods that are plagued by high levels of community violence. The other opportunity I want to talk about is Medi-Cal administrative activities. Medi-Cal administrative activities fund activities related to outreach, referral, support, and coordination, and other administrative costs such as translation and program planning. It's essentially the non-clinical activities that support the administration of the Medi-Cal program, and it covers a range of activities, but the ones that are probably of most interest to community pathway providers is potentially referring Medi-Cal eligible families to covered services, or helping families that are eligible for Medi-Cal but not yet on it enroll so that they can access the covered services they need. And then it can also support coordinating care between those services. One thing I do want to highlight is that the care coordination does not include enrolling folks in social services like CalWorks. So if that, I think one of the challenges of MA claiming is families are going to come in with many needs, some of which are MA eligible, but not all. However, we've seen examples from FRCs in San Francisco and from probation departments in Santa Cruz and other agencies that, the work of connecting families to Medicaid eligible activities can generate significant funding in the 6 or even 7 figures. And so it's not a easy process, but it can be a good source of revenue, especially if you don't want to pursue one of the other possibilities like the staffing of the CHW. It also, I think what's unusual is it can support program planning and administrative infrastructure costs, which can sometimes be hard to fund through other avenues. And then in terms of types of Medicaid administrative activities, there's 3. CMA, or community-based Medicaid administrative activities, focuses on CBOs, schools, local health departments, and it emphasizes outreach, referrals, and care coordination. It's always administered through what is known as a local government agency that may be public health, but is not exclusively public health. And if you are a CBO partner, this is the type of MA you would most likely pursue. Mental health MA is specific to mental health programs and supports the administrative functions tied to accessing behavioral health care. And SMA, or school-based Medicaid administrative activities, is administered through schools and supports Medicaid access for students with disabilities or other eligible children. I don't know much about school-based Medicaid administrative activities, but there are pilots from other states that have shown how this can generate significant revenue for schools. For example, with like a school wellness center or community schools, that this could be a possibility worth pursuing. And then briefly, MA is typically claimed through time-based cost allocations. This means that staff have to complete time studies, and then the activities that they are doing are coded as either Medicaid allowable or non-allowable. And then the time percentage used, the percentage of time used on Medicaid allowable activities is used for cost reporting to get the 50% federal match. So if a program is, I'm just making up numbers, but if a program is spending $100 a day to run, but only 50 of those dollars qualify towards activities that are Medicaid reimbursable, then the 50% match would only be on that $50. So you would get a $25 match. And so the first step to getting started on CMA is to reach out to your local government agency. And then what they will normally tell you to do is they will help you with conducting a feasibility study that will look at how your staff time is being spent, and your funding sources for the program. And then they will work with you to assess whether or not it's a viable program for CMOF funding. But I have talked directly to some LGA administrators, and they are positive, and I would say like encouraging about the possibilities of CMA to support prevention work. And many FRCs across the state have already started pursuing this avenue. And so let me just get through a couple more slides and then we can pause again. So taking a big step back and thinking practically what all of this information means, and I know it's a lot of information, regardless of what Medi-Cal funding stream you're interested in pursuing, the first step is to actually look at your program design. Is to think about the location of your program, the activities the program is going to complete, who the target populations are, and then evaluate alignment with some of the different Medi-Cal funded services that are out there. You can also look at preferred providers within your network that already have the capacity to bill Medi-Cal, or would be willing to bill Medi-Cal but need technical assistance to do so, and look at whether or not they are a good fit for community pathway settings. And then you can look at the organizations that are currently billing Medi-Cal and decide if you want to do outreach to see if they are also a good fit for your community pathway. And so what I mean by this, for example, is I did a network analysis for one county, and I looked at, based on their managed care plan directories, what was their network of providers who were providing enhanced care management. And they had 26 providers across the county providing enhanced care management, but only 5 of those providers were already under contract with the Child Welfare Agency or in that Child Welfare Agency's directory of available services. And so, 80% of the providers were not known necessarily to the Child Welfare Agency, and they were missing an opportunity to do outreach to those providers and see if any of them would be a good fit for their families. And I actually saw an even more striking disparity when we looked at community supports. So actually, before we get into questions, let's try practicing thinking, like applying this thinking to a hypothetical community pathway design. So in this scenario, a county wants to address substance misuse in new mothers, and they're thinking about how they can leverage plans of safe care as a potential community pathway, sending community-based staff or parent advocates to the hospital to be the ones to develop the plan of safe care, which could also, in the parlance of 4E prevention, be a family well-being plan, and follow up with the parent after discharge to support connection to services as needed and identified in their plan. And so my question for you as a group is, what are the staffing roles that this program design might require? And how would those roles overlap with Medi-Cal reimbursable positions? And I'm going to give you a hint. There are many reimbursable positions. There's not one right answer for this. So Regina, I can't really see hands. So if you could call on folks who raise their hand to answer questions, I'd be very appreciative.
Absolutely.
Is anyone raising their hand? Any ideas?
Nope, no one's raising their hand.
Can you show
Okay.
the scenario again? Can you just show the slide? Thank you.
I think Amber rose her hand.
I did. I was gonna, but that's a great idea to have the scenario again. I was just gonna try. I
Go for
don't
it.
think this. I'm okay with failing, but it seems like in terms of staffing, you would need somebody at the hospital. You would need someone or an agency that's going to go do the family well-being if it's assessment, if it's not the hospital staff, or it could be the hospital staff. Is that what you're asking us to do, Katie?
Yeah, so I think I'm asking, that's a step in the right direction. I'm
Okay.
asking to think about like, and you already started to name this, like, what are the things that need to happen, right? So, for example, you said someone needs to go to the hospital and meet with the mom. That's outreach.
Mm-hmm.
They need to make a plan. That's assessment. They
Okay.
need to connect to services. That's care coordination. What uh what's something I presented that would align, like what is a type of staffing position that Medi-Cal pays for, whose job is to do outreach, assessment, and care coordination? And
The
there are
one
some I didn't talk about, but like there's one I just mentioned as an obvious example.
I'm glad
Shelley
I
has
have
her
friends
hand
in the
up.
chat. Yeah. They,
Go ahead again. I can't see hands, so Regina,
Hi,
if you can.
sorry.
Go ahead, Shelley.
I'm really glad that you had this as an example because this is exactly what we're trying to do in San Francisco, pretty much. So,
Mm-hmm.
um, and so based on what you're saying, it seems like Ma could cut like SEMA, no,
Mm-hmm.
SEMA could cover um the outreach and referral kind of
Mm-hmm.
um work. Um, and enhanced care management could be the follow-up
Mm-hmm.
place. Um, and um, I'm or a CHW
Mm-hmm.
doing it, although I feel like the CHW might also benefit from working in conjunction with someone else depending on their background
Mm-hmm.
because of the intensity of the subject.
Mm-hmm.
But I don't know. Am I
Yeah,
close?
all of those were right answers. All of those were right answers. And in fact, on the CHW side, there's even like there are the CHWs that are funded through their managed care plans, but there
Hmm.
are also comparable positions that are funded through specialty mental health services that
Uh-huh.
are specialized in connection to
Oh,
substance
uh-huh.
treatment services. And so this is an example where if I were thinking about how to build this community pathway, I would convene not only my like prevention planning team, but I would ask behavioral health to send someone who understands the like SAPC funded services.
Uh-huh.
I would ask the local government agency to send someone who understands CMA funded services. I would talk to some of your like, I would talk to if you have like a dependency, if you have like
Hmm.
a drug court or like an organization
Yeah.
that supports family and drug court. I'd ask them because they often are quite savvy about how to bill Medi-Cal for the services they provide.
Yeah.
Um,
And
and
as
go ahead.
Clarissa in the chat was saying, like, we're also kind of talking about, like, can't we do this when they're pregnant? So,
Yeah,
so
yeah,
that
you
before
can.
they get into the hospital and are giving birth and all of that, kind of thing. So that's a good kind of, the only challenge, at least in San Francisco, is our experience of MA funding is that the reimbursement or whatever doesn't come back for quite a long time because of how it's
Mm,
processed. And so it's
hmm.
difficult to figure out how to finance something with it because you almost have to have money you have to have the funds to front the work
Yes, you have to
in
have
order
that
to
local
be
dollar
able
first.
local dollar first, and then you don't get the match until, 6 months, a year later, which is,
Hmm.
it's hard, it's difficult. So,
Hmm. And that problem also exists in the 4E prevention space.
hmm.
4E funding, once it's really up and running, it'll get reimbursed quarterly, but there will be a
Hmm.
significant lag for agencies.
Right.
The other benefit that I haven't talked about today, but I just want to lift up there is doulas. Doulas are actually authorized to, meet with mom in the hospital and do some of these services, and then follow up with mom in the home for a limited number of visits. And then I think, and this comes back to Timothy's question, how might you transition? Like we've talked about how you might use Medi-Cal to fund the early engagement with mom, the development of the plan of safe care / family well-being plan, and to identify services the mom needs. How might you transition this mom to 4E funded services? Does anyone have any ideas on what that might look like?
Jennifer has her hand up.
Go for it, Jennifer.
Hi, Katie.
Hi, good to see you.
I mean, I think depending on the threshold, this is potentially FFPSA, the federal funds eligible, I would guess, based on the facts.
Exactly. Exactly. So, the whomever the person is who's gone out to meet with the mom and conducted an assessment, depending on whether they're also a community pathway provider, they could then input this family's details into the CARES provider portal, get approval that this family qualified for 4E prevention services, and then they could connect that family to a funded EBP, like one of the home visiting programs. Or they could use motivational interviewing to continue working with that family and encouraging them to get into services that are not 4E funded, but 4E would cover the ongoing case management of working with that mom. And so this is an example of, this is, I think, many counties are really interested in how to like sustainably fund and beef up their plans of safe care programs. And it's a really good example of, there is a lot of ways to use Medi-Cal for the initial outreach, assessment, and like service navigation. And these families are generally going to also qualify for 4E prevention services. And so 4E prevention can kick in. This is a great way to like blend the funds. 4E prevention can kick in to cover some, the federal match on ongoing support to the mom and family. Okay, let's go through another scenario. And all of my providers on the line, I'm really looking for you to jump in here too. So in this scenario, a county has a local FRC that provides outreach and advocacy around healthy early childhood development, similar to the Promotoras model. They are also operating a home visiting program that uses an approved EBP model for 4E prevention services. And they are offering services in both Spanish and English. And so I'll come back to this scenario, but I think my question here, and this is really, how could local government agencies incentivize this FRC to become a CHW provider? Because those outreach services align very well with CHW services. And what barriers should they be prepared for the FRC to encounter? And how could they support the FRC with addressing those barriers? So again, the question here is really, how could public agencies or PS planning groups support an FRC towards embedding CHWs into their programming to support their outreach and advocacy work and connecting to a home visiting program? Wendy?
Yeah, I'm really appreciative of your scenarios, just because it's very real. It's a lot of services that have multiple funding stream attached to it, right?
Mm-hmm.
And so, for example, you talk about home visitation. There's not just only Medi-Cal cover, but if a child comes into the care, like the Title IV round, right? Then the provider would have to provide that service to the fidelity to be able to enter into the carer's framework, right? And so to tap into the Title IV funding. Then you also have Medi-Cal involvement with the health concern. So again, I'm loving the scenarios for us to tease out, but ultimately I feel that the state needs to provide a very clear guidelines and guidance for all of us, instead of just kind of guessing how do we braid and blend fundings together. So that's just a thought that I have. So.
I mean, I agree, because it's incredibly nuanced. And so...
And no one wants to pay first. And how do we pay first?
Yeah,
and
everyone's a
how long do we pay for it? Is it 3 months, 6 months? So...
And I think so. I think to your point, for example, though, in this scenario, actually, before I jump in, Patty, do you want to weigh in? I saw your hand up.
I'm going to echo what Wendy said, right? Because I mean, the state provided us with an all-county letter saying FFPS is payer of last resort, right? And trying to maximize Medi-Cal dollars as much as you can, but they haven't provided additional guidance. And we're trying to figure out, what are the intersections of where can we leverage some of these fundings, right? How can we leverage the managed care plans, and what is billable to Medi-Cal that fits into this So how is the FRC or the provider going to pay for that staff time for that initial engagement, right? And this is something I really love you bringing up. How can the community health workers be used for that upfront, right? And that engagement and assessment, because that's the part that I think it's important. And once they assess, and it's like if the family needs the population of focus and the candidacy determination, right? Then we can look at what EVPs can help address those concerns that are also billable to Medi-Cal or can draw down for each office. So I really love how you put the scenario. Thank you. And Wendy, I agree. It's like we need more direction.
Yeah, thank you. I appreciate all of those comments. And I think to your point, what I think I'm trying to encourage here is to think about using, say, the CHW, or in the background CMA, to basically cover the work that the county is doing around the outreach and advocacy. And then those workers are very well positioned to identify the families who should be escalated to 4E prevention services and enrolled in that home visiting program. Sarah, I see your hand up.
I'm sorry to say we couldn't hear Patty at all. A lot of people were putting it in the chat. We couldn't hear her. It was very, very faint, Patty. So I don't know, Katie, if it's possible to just kind of paraphrase what Patty shared, or how to quite do that so the group is not lost.
Sure. So Patty had, I think, two major points. Patty, correct me if I'm wrong. Her first major point was reiterating what Wendy said about really wanting more concrete guidance around how to braid and blend funds. And then she was appreciating that this is a problem. This, how do you first conduct outreach and identify these families who are going to qualify for the 4E pathway? And so she was basically processing the concept of really using CHWs to be that pipeline for the first touch through the assessment and referral into 4E prevention services. Patty, did I faithfully capture your points? And if not, you are welcome to correct me.
Yes, you did. Thank you, Katie.
Okay, I see some more hands up. Regina, can you give me the order?
Yeah, it's Suzanne and then Letitia.
Okay. Suzanne?
Oh, hello. I'm sorry. I don't see my camera, but
okay.
I think
I hear you.
I unmuted.
Yeah,
so,
yeah.
What I'm kind of conceptualizing, and there's so many variables here, is you mentioned just when we were talking about the community health workers position and their capacity to pretty much identify high risk. And so maybe that would be a good mitigating or a good mechanism to use that motivational interviewing to help the person understand, wow, I've got this new baby and this history, and with the help of community and so forth, maybe I can change the trajectory and provide this child with all the health and receive all the help I can myself, so to motivate that person, and also to have them be able to testify that they are going to be a candidate that is going to really push for success, which is also going to increase likelihood of the dollars returning to them. But also, I'm also thinking a little bit of, in CWS, they have the CSNAs, the risk assessments, and the state risk assessment. So even utilizing something like that, I don't know if a community health worker could utilize something like one of the evidence-based risk assessments to, again, take to the powers that would fund that particular case and be that advocate that can pull in the tools and the numbers that will show the level of risk is high and the predictability that this person is buying into and wanting to.
Yes, you're correct. So I think you're bringing up two important points. The first important point is that the CHW or whomever is providing this role is in a position to conduct an assessment. And you know, the state has given counties significant leeway over what they use to determine 4E candidacy. So there isn't a prescribed assessment that they would have to use. But for example, with HFA uses a risk assessment and then what's known as, like, I think the frog assessment. And that assessment hits a lot of the same points that are needed for the 4E candidacy. So the worker is in a good place to both assess the family's appropriateness for, like, say, the home visiting program that the organization offers, but also to look at candidacy overall. And then I think the other point you made is that there's no need for the CHW to then refer out to another EVP there. And this comes back to actually to Timothy's original question. There is nothing preventing that worker from being cross-trained in MI and being authorized to provide MI for cross-cutting case management. And so in this braided funding model, Medi-Cal would pay for the first 3 encounters that the worker did to meet with the family, you know, provide early assessment and advocacy and understanding their needs. And then if the family needed more engagement than that, the worker could complete the assessment and say, I want to keep working with this family using MI. And that would qualify all of the case management costs associated with working with that family for 4E prevention reimbursement. Letitia? Or Leticia? Sorry if I pronounced it wrong.
Sorry.
Hi. No problem.
Well, I just kind of I like your scenario that you're presenting. I work for First 5 Humble, and we're actually going to do this transition then to use Medi-Cal as a future income for our services. So I will answer into the first scenario. I think the first thing that we have to go through, it was like train staff, which is a lot of income to train staff and make us all CHW employees or certified. And then also we have to talk about investing in technology or somebody who will be able to send us or navigate Medi-Cal. And I think the other issue that we're still confronting is the fear of losing that trust on families, you know, like I don't know if you guys are familiar with playgroups, but we are offered 2 hours of families coming and playing. And my job as a navigator is just go and chat with them, help them through answer to developmental questions or any concern, or send them to resources. And the challenge that we're having to move to work with Medi-Cal or in this possible future, because it seems to be like the only option right now, is that first, we feel that we need to ask them for their medical insurance, which has never been a thing. And the fear is to lose their trust. The fear is to lose, especially with undocumented families or families that have mixed status. And also the other fear is to all this investment for super delayed coming back, income back. So I really appreciate your conversation because it's just kind of opening my eyes in how long it's going to take to do this. I mean, we're fortunate that we were able to certify as CHW workers 3 of our navigators already. And we visit those play groups. We're constantly reaching out and giving information. And I hearing before a slide before, it makes inspiring that we could still already start like charging or to Medi-Cal, because we constantly giving information about early child education development. We do a lot of ASQs. We refer to early child intervention. So it's very interesting. But that is the thing. I think the biggest challenge that we're going to have is first, lose the trust of families. And the second is the investment on putting all these new force and train them again, and then learn how Medi-Cal works. And I know Medi-Cal always takes a little bit to refund. So I just wanted to add that.
Yeah, I think in the interest of responding to your points and some of the points that came before you, I think what I'm going to do is I'm going to skip scenario 3 for a moment, and we can come back to it if time allows. And instead, I want to talk about what's the catch with all of this, right? Because the administrative load to provide, to become a Medi-Cal provider of services is high. And it is not something we should expect provider communities to be able to navigate independently at the level that prevention planning groups are going to want for like really good saturation of community services for their target populations. And so let's talk a little bit through the challenges and the role that public agencies and like systems of care can play in supporting the development of robust networks. So the first thing I want to talk about that is really hard with Medi-Cal funding is that for a provider to begin billing Medi-Cal, they have to get certified to do it. And even knowing how to start that process, it's service dependent, right? So for example, if you're a CHW provider, you first have to get certified through DHCS. And then if you want to bill a managed care plan, you then have to contract with a managed care plan. If you want to bill CMA, you have to be under contract with your local government agency that administers CMA. If you want to provide ECM, you have to get under contract with your managed care plan. And for some, specifically for ECM, and I think in the future, possibly other services, there is a possibility of going through an intermediary like Full Circle Health Network. But even mapping out what do we want to offer and what's the road to getting billed is complicated. It's nuanced. And it generally requires significant administrative capacity. So for example, for organizations that use an intermediary like Full Circle Health Network, the way it works is that Full Circle Health Network takes 10% of all of the revenue they generate from Medi-Cal to cover the administrative costs. And so that cut is much more efficient than most agencies can cover internally, like to cover administrative costs associated with Medi-Cal. And so that tells you that if you're planning to become a Medi-Cal provider, you need to plan for administrative costs as part of your kind of fiscal modeling of what is the lift. And then it's also really nuanced, right? So as I said, depending on the services and the biller, expenses are reimbursed through claims submitted directly to the state, or they're submitted directly to the managed care plan, or they're submitted through intermediaries like the LGA. And all of that creates delays on when you can expect funding. And so what it means for systems of care is that they should expect implementation challenges for providers. They should expect providers to face informational gaps, capacity gaps. They should expect to need to provide fiscal and technical support to mitigate the risk of investing in becoming a Medi-Cal provider. And recognize that particularly for things like FRCs that rely heavily on local dollars, if they can increase the proportion of federal revenue those agencies are able to claim, then everyone can save money in the long run. But that there is an upfront risk to investing in this change, and they shouldn't necessarily expect their provider communities to bear that risk alone. Planning committees also need to think about the managed care and the Medi-Cal landscape within their own counties. Urban counties tend to have multiple plans. Those plans don't necessarily overlap heavily in who they contract with, and that creates complications for a provider who just wants to be an access point serving everyone who comes through the door. And so I think when we think about how agencies can support the development of Medi-Cal funded and 4E funded provider networks, they have a couple levers they can do. I'll start with number 3, which is just straightforward. Just offer technical assistance support to stand up Medi-Cal certification and contracting with managed care plans. We've done this in a couple of our demonstration sites for CalAIM, and our experience has been that community providers are often aware of the benefits of Medi-Cal funding, and they are overwhelmed to do it alone, and they need significant training, and they really benefit from having someone who understands the certification process hold their hand through it. And they also benefit from having some short-term subsidies to help offset the administrative costs of getting started. I would say the other area that is more of like a long-term stick is start building into your procurement process preferential status for providers who can build capacity to bill Medi-Cal and braid funding as part of their RFP requirements. Doesn't mean that you don't contract with organizations that can't. It just means that organizations understand that by building this capacity, they are actually investing in their long-term ability to win county contracts. And then the last piece is for performance-based contracts. Because it's less expensive for agencies to send families to providers who are offsetting the cost of serving the families through Medi-Cal, you can prioritize referrals to organizations that have braided funding capability. And so again, this isn't meant to be like an immediate stick that you beat your provider network around. It's meant to signal, we are moving into a world where braided funding is increasingly necessary. And how do we create confidence that these efforts will be rewarded over time? And so in terms of, and this is my last slide, and then we can transition to questions or go back to the scenario. I know we only have about 10 minutes left. In terms of concrete steps that prevention services planning teams can take to start thinking and exploring this today, I would say that there's 3 steps and 2 things to think about. So the first step is to really, as a team, learn more about what Medi-Cal pays for, how it's administered, and what the opportunities are. I only touched on 2 today, but there's many. And then really map out what is it that you want out of your community pathway, and of those activities, what might qualify for Medi-Cal funding, and then conduct an analysis to think about, are those activities better funded through CMA? Are they better funded through one of the CalAIM provider class positions? Are they better funded through a benefit like ECM? And really think about, the opportunity and the cost of pursuing any of those avenues, and engage your managed care plans. I think something I didn't mention on this slide is providers do run into problems trying to engage with managed care plans. And child welfare agencies and other public agencies who had to sign an MOU with managed care as part of CalAIM are in a position to influence those conversations and put pressure on managed care plans to go out and contract with the trusted organizations that child welfare or other organizations want to work with, right? So many managed care plans they went out and they contracted with the first providers who could get all the paperwork in, but those might not be the providers that your community trusts. And so there is an opportunity to, bring managed care to the table and apply pressure to go out and work with the providers that your community trusts. And then the last piece is, so for your preferred providers who you want to put community pathway services in, because they're trusted by your community, but they're not currently billing Medi-Cal, what's the technical assistance they need to address that gap? And then also go out and look at who is billing Medi-Cal in your community that you might want to conduct outreach to, because maybe they're a great provider who can fit a bunch of your needs and should be a community pathway provider as well. And it's just about building a relationship. So those are the 2 prongs. And I think with that, I will shift to questions, unless people prefer to go back to scenario 3, which is about community supports.
Patty? We have a lot of questions. So
okay, well, why don't we focus on questions then? And I, slides are in the handout on the app, and we can, anyone who wants to follow up on scenario 3 can reach out to me directly. Go ahead, Patty.
So Katie, I'm working very closely with the providers, and something that you said caught my attention as to how can we help the managed care plans partner with those community pathway providers. A child welfare is required to do, MOUs with our managed care plans. Would it be something that can be added to that MOU to, have them really intentionally reach out to those community pathway providers that we already have contracts with?
Yes, and in fact, I think we actually talked about this with Jackie, and you're on your end for Santa Clara. You can insert language into your MOU that the managed care plans balk at this language. And so the midpoint is that managed care plans will make a good faith effort. That's kind of the limit of what they're willing to be held to, that they will make a good faith effort to contract with the organizations that are also heavily utilized by your client population, right? So you can definitely write that clause in. And I think it was in one of the early versions of the DHCS like edits. I think it got taken out, but if you reach out to me later, I can give you that sample language from a template we wrote.
Great, thank you. And then my other thought and kind of question with that is, you know, working with some of these providers, I'm realizing that they tend to be siloing the work even within their organization, right? Because the department or the programs that are billing to Medi-Cal are separate from and separated from the staff that are doing the community pathway. So when I have conversations with them of, hey, since you know how to build Medi-Cal, you need to start looking at how, you know, what components you can build. They're like, well, we don't do that. That's a separate team. And so I feel like there's a lot of technical assistance that even the providers that can build Medi-Cal to guide them on how do they really build that integrated infrastructure within their organization to see everything, right, holistically as to what they can build Medi-Cal when families come into their door.
Mm-hmm. Yeah, and I think this gets back to your point and Wendy's point earlier of there is this tremendous flexibility and room for creativity. And the downside of that is it really precludes like the state giving clear-cut guidance on like scenarios, right? And so I think until this gets better fleshed out over time, it's why I really encourage this issue to not be addressed in individual spaces, like just by a provider or just by an agency, and actually system of care spaces and FFPS, like, you know, prevention cross-stakeholder team spaces are the right spaces to talk about how can we collaborate to be creative about addressing these issues, because organizations may not get there on their own. Okay, Regina, I don't know if we're going to have time to get through all of the questions. Can you pull a selection for me? I think we only have 5 minutes.
I know, you only have 5. I was just going to let you know. So where can we find information on rates of pay to determine which is better?
So this is tricky because it depends on the service and they're not all in one spot. And so, and then it gets even more complicated because, for example, with CHWs, there's a base community rate, and then there's like a different rate that's like the clinical rate. So that means if the referral came through and like a clinical provider initiated the CHW service, so which pays like almost double the base rate. And so I think my email's here. So I think the best way the best short answer I can give is there is a lot on the DHCS website. But if you are looking for something specific, feel free to email me and I can research your question and get back to you.
All right, and our last question, do CBOs have to go through the PAVE process as they contract with MCPs?
So for specifically CHW services, they currently have to go through the PAVE process. And I have seen this be a barrier for some CBOs. And the reason that they have to go through the PAVE process is because CHW services are also available to individuals on fee-for-service Medi-Cal. And fee-for-service Medi-Cal is claimed directly to DHCS and not through a managed care plan. And so there's a chance with advocacy this will change. But for now, the process of having CHW services is you first go through the PAVE provider process, registration process with DHCS, and then you go contract individually with managed care plans. That doesn't apply though to plan services that are exclusively offered through managed care plans. So for example, to become an ECM provider, that is a direct negotiation with the managed care plan and you don't need to do the PAVE process for that. And similarly, I don't think you need to do it to become a community supports provider. I believe you said last question. So, and I know that we are at 2:07. So I think I just want to close on, we only scratched the surface of this topic. And there are resources. I hesitated to put a dozen handouts into the app but there are resources out there to help better understand things like the new provider classes, CalAIM requirements more generally. Our firm has lots of resources around 4E prevention. And so please feel free to just reach out to me. My email is on the slide. And I'm happy to have a follow-up conversation and, guide you to more resources as I'm able. And I think with that, we are done. Thank you all. I'm going to stick around for a couple minutes just to read through the chat, but thank you all for your time.
Thank you very much.
Thank you, Katie, very much. Really a lot of great information.
Thank you.
And we'll go into break now. So you have about a 15-minute break, and then we'll come back and you'll move into your second workshops.